everyone for joining Health for the World International Grand Rounds. We are really honored to have our Grand Round speaker, Dr. Lucy Muinov, and our moderator, Dr. Amy Oliveira. Dr. Amy Oliveira has kindly agreed to moderate the session today. Dr. Amy Oliveira is Assistant Professor of Radiology at UMMS Bay State Medical Center and also leads our UMMS Bay State Health for the World chapter. Dr. Oliveira will be moderating the session today and introducing Dr. Muinov. Thank you so much, everyone, for joining, and I hope everyone has a great session.
Thank you, Dr.
Good morning, everyone, and thank you for the opportunity to introduce Dr. Lucy Muinov. She is an associate professor of radiology. She's at the University of Nebraska Medical Center, where she did her training for medical school, internship, residency, and stayed for fellowship in abdominal imaging. Her research focus is on diffuse liver disease, and today she will be speaking to us on imaging of the adrenal glands. I'd like everyone to join me in welcoming Dr. Lucy Muinov.
Thank you, Dr. Oliveira and Dr. Rihani. I appreciate for the invitation. It's good to be back. So today my lecture will be imaging of the adrenal glands. So I will share my screen. This is a lecture that I commonly give to our radiology residents every year. It's a part of our curriculum. So we'll go ahead and get started. So adrenal glands are a part of endocrine and nervous system. They regulate metabolism, salt and water balance, response to stress. They produce cortisol and epinephrine, and they also play a part in sexual functioning. Unfortunately, adrenal glands are also a common site of hematologic metastases. Such malignancies as lung, melanoma, and breast will commonly metastasize to the adrenal glands. So it's important to know what adrenal glands look like normally so that we can detect pathology when it's there. Anatomically, each adrenal gland consists of several parts. There's a central part called body, and then there are three limbs or crura. There's anterior, lateral, and medial crus or limb. We use those terms interchangeably. Some radiologists prefer to say crus, other radiologists will say limb. Usually it has a pyramidal shape. Sometimes we describe to students a V or Y shaped or Mercedes-Benz-like structure. Each gland is 7 to 10 grams in weight. They lie within perirenal space. Each crus normally is less than 5 millimeters thick, and that central part called body is usually less than 12 millimeters in thickness. This is a picture from StatDX that shows the anatomy. So bilateral adrenal glands are retroperitoneal structures. They're in the perirenal space, just above the kidneys. They're usually lateral to the crus of the diaphragm. The right one is posterior to the IVC, and the left one is posterior to pancreatic body and tail. This is another picture showing vascular supply. So there's a very small branch off of the aorta called middle adrenal artery, which will supply a part of the adrenal gland. Sometimes it's hard to see. You really have to have a sharp, crisp angiogram if you're going to find that such a small branch. And there's also superior adrenal arteries, which are a branch of the inferior phrenic artery. In cross-section, the adrenal gland, again, has that pyramidal shape. On the outside, there's a capsule, and then the outer part is called cortex, and the central part is called medulla. They have completely different functioning, okay? Even though it's a part of the same organ, the functioning is much different. The outside cortex functions in the endocrine system, and the inside medulla functions in the autonomic nervous system. So cortex produces cortisol, aldosterone, androgenic steroids, and central medulla produces epinephrine and norepinephrine. In an adult patient, a lot of times it's hard to find a normal adrenal gland. In fact, usually adrenal glands are not a part of the routine abdominal ultrasound on an adult patient unless they're abnormal, unless there's a mass or a large nodule. Then the sonographer might see it as abnormality. Versus in a child, this is an ultrasound image of the right abdomen on a child, where adrenal gland will be proportionately larger to the rest of the organs, and it will have that hypoechoic outer part and the hyperechoic center. So they're more visible on the child as a normal finding. On an adult, most adrenal glands will not be visible when they're normal. On CT, again, this is cross-sectional contrast-enhanced image of the abdomen. This is the left adrenal gland, again, that central part we call body, the anterior, medial, and lateral cruise. Some people think that it looks like a Y or a V or a Mercedes-Benz sign. On an MRI, adrenal glands will follow the routine signal intensity of the remainder of the solid organs. Again, here's a coronal image on T2 and an axial T2 image. They're usually small and smooth and thin, and the adrenal glands will enhance usually just homogeneously as the remainder of the solid organs, such as spleen and liver and pancreas. So now we'll talk about adrenal lesions, masses, and pathology. I will present several cases and then we will work through those cases. So this was an exam, a CT with oral contrast, but no IV contrast. And there's a well-marginated solid mass in the right adrenal gland with oval shape and smooth margins. And if we put Hounsfield units, measure the density of the mass, the average Hounsfield units is 8.6, so about 9. So less than 10. So we have a solid mass with circumscribed margins, average Hounsfield units of 9, okay, or 8. So these are typical imaging characteristics of a benign adrenal adenoma, which is the most common mass or lesion within adrenal cortex. 10% of population will have these benign adenomas, 10% are bilateral. Patients with diabetes and hypertension have higher incidence of adrenal adenomas. 70% of these adenomas are lipid-rich, while 30% are lipid-poor. So the lipid-rich adenomas are much easier to diagnose, especially if we have a non-contrast CT, or they're fairly easy to diagnose with MRI as well, versus the lipid-poor adenomas, which are sometimes harder to diagnose, especially if we don't have a pre-contrast scan. All we have is a routine venous contrast-enhanced exam. Sometimes it's harder to diagnose a lipid-poor adenoma rather than lipid-rich, but luckily most of them will have the typical oval or round shape, smooth margins, and Hounsfield units between 0 to 10. So there are two types: non-hyperfunctioning, which have normal hormone levels, and hyperfunctioning, which could result in several clinical syndromes, including Conn syndrome, Cushing's syndrome, or hyperandrogenism. Now, by imaging, we cannot tell if the adenoma is non-hyperfunctioning or hyperfunctioning. All we see that it's an adenoma, and then the clinical doctors will have to do the lab work, biochemical assays to determine whether the adenoma is functioning or non-functioning. This is another picture from StatDX, which shows us that mass, smooth, solid mass within the adrenal gland. And this is a pathologic picture. Again, here's the adrenal gland, and we see that adenoma. So we have multiple protocols in our department, just like in most other body imaging departments, designed to answer a particular question. So for example, we have an adrenal mass protocol. So if the indication says indeterminate adrenal nodule, or rule out adrenal mass, rule out adenoma, pheochromocytoma, then our residents will protocol that particular exam to be done with what we call adrenal mass protocol. And that protocol will involve several things. The first thing that we will do is a non-contrast CT of the abdomen. Usually we don't image pelvis unless there's something else that we're looking for. And then at that point, the technologist will keep the patient on the CT table. They will give us a phone call in the reading room, and one of us staff radiologists or resident will look at those images while the patient is still on the scanner. And we will measure the Hounsfield units of the nodule, if there is a nodule, provided there is a lesion. If the Hounsfield units are less than 10, and it has a smooth margin and oval or round shape, then we will call it an adenoma. We do not need to give IV contrast. If the Hounsfield units are greater than 10, then we will tell the technologist to continue with our multi-phase protocol and give IV contrast. And the multi-phase protocol will include the routine venous phase, which is a 70-second delay of IV contrast, and then wait 15 minutes and do a delayed scan. Okay, so you can see how this is triple the radiation. Unfortunately, we did a non-contrast routine venous phase and a 15-minute delayed scan, but it's a small area. We only image through the adrenal glands, and usually part of the kidney, but it's three scans. And this is how our protocol looks like. Again, we do a non-contrast 2.5 millimeter slice thickness showed to radiologist, and then we do a 70-second routine venous phase, followed by a 15-minute washout phase. Okay, so how do we diagnose an adenoma on the non-contrast enhanced CT? As we said, usually circumscribed low-density mass, Hounsfield unit 0 to 10, lipid-rich adenoma, which is majority of them, will have Hounsfield units less than 10, which is diagnostic. At that point, we can stop with the non-contrast CT, versus lipid-poor adenomas, the 30% of them will have Hounsfield units 10 to 30. So if that's the case, then we will proceed with contrast-enhanced washout protocol. And a benign adenoma should have rapid de-enhancement. So 10 to 15-minute delay. In our institution, we do a 15-minute delay washout. We calculate the washout, and if it's greater than 60%, then we confidently diagnose an adenoma. Okay, so an example, contrast enhanced CT has Hounsfield units of 50, so this is routine venous phase, and then 15-minute delay Hounsfield units of 20, so then we calculate the washout, and if it's greater than 60%, then it's an adenoma. Okay, so there are several different ways of doing this. There's absolute versus relative percentage washout. We rarely have to do the relative percentage washout. Most of the time, we will have the true protocol with and without contrast, where we can do the absolute washout. So absolute percentage washout is used when imaged with adrenal protocol CT. Unenhanced CT is available, okay, versus relative percentage washout is in those cases where all we have is a contrast enhanced CT, which is majority of our scans done for, let's say, abdominal pain or staging scans for cancer. We did not do a pre-contrast phase. And so if we catch it early enough, we can bring the patient back and do a 15-minute delay. So we don't have pre-contrast, but we do have routine venous phase and 15-minute delay, and then we can calculate the relative percentage washout, and if it's greater than 40%, again, we can diagnose that nodule as an adenoma. So here's an example again from StatDX, which is a very useful tool that I use nearly every day for teaching and for my own learning. Here's a case of a circumscribed adrenal nodule with non-contrast Hounsfield units of 30. So this would not be confidently diagnosed as lipid-rich adenoma because it's higher than 10. And in this case, they did post-contrast with washout. So this is routine phase, and this is a washout. So you can see 80 versus 45, and the calculations still make the diagnosis of a lipid-poor adenoma. On MRI, the adenomas have typical appearance. Usually T1 weighted imaging is what we want to be looking at. The T1 and T2 can have variable appearance, but the special sequences that we always want to see for adenomas are the in-phase and a post-phase T1 weighted imaging. And we're looking for signal dropout. So on in-phase, the nodule will be iso-intense to the remainder of the solid organs. And on a post-phase, we will lose signal, so that nodule will become nearly black or very dark. Okay. Here is an example of T1 in phase. You can see that nodule is about the same signal intensity as the liver. And on a post phase, there's loss of signal. That nodule becomes nearly black. Again, with the circumscribed margins, it's a confident diagnosis of benign adenoma. Even in a patient with, let's say, primary malignancy, these features are characteristics of an adenoma. Here's another case from STAT-ZX where there's a nodule and it loses signal on a post-phase or out-of-phase imaging. And at the same time, we can also see that the liver is doing a similar thing where it's bright on in phase and then it loses signal on out of phase, which is a diagnosis of hepatic steatosis or fatty liver. Here's another case from STAT-ZX that they show a very unusual appearance of an adenoma. It's a large mass. It has some perhaps cystic components, low density components, also some enhancing nodular components, and a calcification. And these are not typical for a benign adenoma. So at this point, this was presumed to be a neoplastic lesion, either adrenocortical carcinoma or metastatic lesion. And you can see that the patient went to surgery because none of these fitted with routine benign characteristics, although on pathology, this was found to be benign, and this was an adenoma that just had some atypical features. So not all adenomas will look that classic appearance of smooth and hypodense with those typical density measurements. So case number 2, this was another patient who had MRI for abdominal pain, and these are T1 weighted images. This is T1 in phase, coronal, and T1 out of phase. Again, we can see some thickening and nodularity of bilateral adrenal glands, but the adrenal glands still lose signal. So on this out of phase imaging, we can see that bilateral loss of signal. So this is a case of adrenal hyperplasia. Some radiologists will call it nodular adrenal hyperplasia, while other radiologists will say adenomatous hypertrophy. In my opinion, my experience, at least in our practice, we use those terms interchangeably. Some of us will say benign adrenal hyperplasia, other radiologists will say nodular hyperplasia. Again, the importance is to relate the message in the report that we think this is a benign finding. Even in a patient with, let's say, cancer, especially if we can prove that they're unchanged and stable, so that the clinician and the patient don't worry unnecessarily that those nodules might be metastatic disease, unless we have a reason to believe so. Unless they're new, unless they're heterogeneous and enhancing and have suspicious margins, then then we can do other testing. But adrenal hyperplasia is common. We see it in lots of patients. I would say at least several times each week that I will dictate either adrenal hyperplasia or adenomatous hypertrophy of the adrenal glands. They may cause Cushing and Conn's syndromes, so they can produce hormones. Adrenal hyperplasia is the most common cause of nonspecific bilateral adrenal thickening on CT. Again, we see enlarged limbs or crura of the adrenal glands, usually thicker than 10 millimeters. They can be nodular or they can just be diffusely enlarged, but no large dominant nodule. Okay, so they're kind of smooth nodules, a lot of times bilateral. Adrenal shape is maintained. You can have bilateral symmetric enlargement. And on MRI, again, we see similar appearance to CT, bilateral, smooth, round, or oval nodules or diffuse thickening. And even if sometimes we see that loss of signal on out of phase T1 weighted imaging, and we will dictate it out as adenomatous change, or you can say adrenal hyperplasia. This was a patient with history of pituitary adenoma and Cushing syndrome. So again, we can see nodular diffuse enlargement of both adrenal glands. So that brings us to a differential diagnosis of bilateral adrenal enlargement. Okay, so it's not always due to hyperplasia. Yes, hyperplasia is common and it's at the top of the list in the differential diagnosis, but there are other things that can cause bilateral adrenal enlargement, such as hemorrhage, metastatic disease, amyloid, sarcoid, hemochromatosis, tuberculosis, fungal infections. So the list is long. Out of these entities, the hyperplasia, hemorrhage, and metastatic disease, in my opinion, or in literature also, they're the most common. Moving on to another case, this was a scan on an adult patient for right upper quadrant fullness and pain. And this is a coronal contrast enhanced image of the CT. And you can see that there's a large circumscribed cystic mass. It looks very homogeneous and smooth. And if we measure Helms per units, it will be water density. It will be 0 to 10. okay? And when we look on axial and sagittal and other sequences, it demonstrated just that there was no solid component, no nodules or septations, just a large adrenal cystic mass, okay? So in this case, the Hounsfield units were 2, and this mass was stable for 10 years. So we could make a confident diagnosis of an adrenal cyst. And the cysts are not as common, in my opinion. Adenomas are much more common in hyperplasia than cysts, but once in a while, there will be a smooth cyst, and it's nice to have a comparison, just like with everything else in radiology. It makes us all feel better to say that it's been unchanged for some time. Usually they will not require any attention or treatment. Sometimes they get very large and they will produce mass effect, and then we can refer them for surgical consultation. Here's another case. This is a contrast-enhanced axial image of an abdominal CT, and we can see a circumscribed, fairly large circumscribed left adrenal mass. So this mass has macroscopic fat. So you can see this low density areas, also some higher density areas, but it's very important for us to recognize that this hypodense tissue is macroscopic fat. So if we measure Hounsfield units here, and we will get a large negative number, for example, -50, maybe -70, -100, I always tell the residents to compare the shade of gray to where they know there's fat. We know there's subcutaneous fat. We know there's retroperitoneal, omental, mesenteric fat. And I will ask them, does this look the same as this fat or any other fat where we know for sure there is fat? Plus, we can measure confidently the Hounsfield units. Okay, so we have a fat-containing circumscribed adrenal mass with macroscopic fat. So this is a case of an adrenal myelolipoma. Myelolipomas are benign tumors of the adrenal glands. A lot of times they will have heterogeneous appearance, and they will have that typical hypodense macroscopic fat. Okay, sometimes it's a small area, sometimes larger area. Most myelolipomas will be 2 to 10 centimeters in size. They can get very large. They can be 10 to 20 centimeters. In our tumor board with surgical oncology, I've seen very large myelolipomas that will be up to 30 centimeters. And when they're that big, it's difficult to differentiate from liposarcoma. And usually these myelolipomas, when they're that large, they will be removed surgically. Okay, as we say here, they can mimic lipoma or liposarcoma. So Hounsfield units will follow fat density, macroscopic fat, -30 to let's say -90 or 100. Usually they're well encapsulated. 20% will have calcifications. Okay, so the most classic descriptor of a myelolipoma is a circumscribed adrenal mass with macroscopic fat, and better yet, if it has calcifications. Okay. On MRI, our best sequence, because we're looking for macroscopic fat, is T2 fat-sat sequence, where we see that loss of signal, again, because it's following macroscopic fat signal intensity, okay? Versus in an out phase, which will look for microscopic fat. So there's differentiation, and the residents get confused which one to use for adenoma versus myelolipoma. For myelolipoma, we're looking for macroscopic fat. We want T2 fat-sat. For adenoma, we're looking for microscopic fat, intracellular fat, and we want to look at T1 in and out of phase. Okay. Here's rare presentation with acute abdomen due to rupture or hemorrhage. So these myelolipomas, especially when large, they can bleed sometimes. So here's another example of a myelolipoma, again, circumscribed right adrenal mass with calcifications with macroscopic fat, very classic, typical appearance. We should confidently be able to diagnose this as a myelolipoma. There's not much of a differential diagnosis at this point. We should say confidently benign adrenal lesion. Here's another case of a circumscribed left adrenal mass. Again, even though it has some solid tissue here, we can still see that there's some macroscopic fat and maybe a calcification. Here's another example, fat attenuation mass with focal calcifications, which are typical features of a myelolipoma. And here's an example of a very large tumor. So at this point, it would be difficult to be confident and say that this is benign myelolipoma. We can see large solid component. Yes, we have some fat, maybe some circumscribed margins, but at this size, most patients will be referred to surgical oncology for consideration of dissection. So moving on to another important concept in abdominal imaging. So most organs, as we all know, will have incidentalomas. So what is an incidentaloma? It's a finding that's found incidentally on imaging. Let's say we're ruling out appendicitis, and oh, by the way, there is an indeterminate adrenal nodule that no one knew about, but now the patient and the clinical doctor will have to deal with it, so to speak. They will either have to follow it, or maybe we need to find prior imaging to confirm that this is just a benign incidental finding. Adrenal incidentalomas are extremely common. Up to 10% of adults will have an incidental adrenal finding. The definition of an incidentaloma is adrenal mass greater or equal to 1 centimeter discovered incidentally on cross-sectional imaging examination performed for another reason, such as we're looking for diverticulitis, appendicitis, and oh, by the way, there is that frustrating adrenal nodule. 9% of autopsies have adrenal abnormality. 5% of CT reports have incidental adrenal finding. There was a paper in 2008 in the American Journal of Rentgenology where they looked at incidental adrenal masses on CT, and they found that adenomas, myelolipomas, hematomas were the most common incidental findings on cross-sectional abdominal imaging. So this is a document that I commonly refer to. We have it saved on all computers in the body reading room. In fact, we have a button for each organ for incidentalomas for kidney and liver and adrenal, so that we can easily find it and refer to it when we are reading our studies. So this is from the American College of Radiology from 2017, Management of Incidental Adrenal Masses, white paper of the ACR Incidental Findings Committee. It's a very comprehensive, very detailed report, and it has a very good chart that's easy to follow. Okay, so when I see an incidental adrenal nodule, because I can't remember a lot of times what the guidelines are, right? It's hard to remember all those numbers, but I know where to find information. I know to pull up this paper and look at this chart, and it's very easy to follow. So we'll just spend a few moments briefly looking at this chart because it's everyday work for us body imagers looking at charts like this. Okay, so we'll start at the top here. I'll magnify it a little bit. So when we have incidental asymptomatic adrenal mass that's greater or equal to 1 centimeter detected on any CT or MRI exam, so we will first go into the benign route here. So if we have diagnostic benign imaging features, such as myelolipoma, we just said if there's macroscopic fat, and better yet, calcifications, we're confidently calling it benign. We don't need to do follow-up. Or if we're confidently diagnosing a benign adenoma with less than 10 Hounsfield units, or loss of signal on MRI, just like what we looked at, again, we're confidently calling them benign adenomas, no follow-up. Now, when we see this one, there's a little tiny one that refers us to this statement here. So for some of these nodules, even though we are confidently calling them benign, but remember, some of them are hyperfunctioning. They might be affecting patient in other ways. They might be causing syndromes and symptoms. So clinician needs to consider biochemical assay, even though it's a benign nodule, but it might be symptomatic. So clinicians need to put it together at that point. Now, on the other side of this, if we have indeterminate features, if we're not confidently calling it benign myelolipoma or adenoma, and the mass is greater than 4 centimeters, so we're not sure what we're looking at. It's big, it's greater than 4 centimeters, no cancer history, considered section. So in our institution, if by imaging we find a large adrenal mass and it's greater than 4 centimeters, nearly all of these, if not all masses like this, will at least be referred to surgical oncology for consultation. Not to say that they will necessarily have a surgery, but a surgeon needs to be involved and they need to do the biochemical assays and to take it one step further. So large masses, surgeons say it almost doesn't matter what we say because anything greater than 4 centimeters will go through that surgical route. Okay. If there's history of cancer, then again, we need to consider biopsy or PET-CT. And again, there's a little one here which refers us to consider biochemical assay. Now we will look at these indeterminate lesions that are greater than 1, but less than 4 centimeters. Okay. So it's always best to have prior imaging, right? I love prior imaging. I have all my outside hospitals in my city and in my state in my phone because I call them commonly. I will say, I need a prior exam on this patient. Can you send it to me? And usually they can send it wirelessly because I can make it better by comparing. For example, if we find a nodule, adrenal nodule that's stable for 1 year, all we need is 1 year, then we can confidently diagnose it as benign and no future follow-up. So if I find that study, then I can save the patient some extra imaging, worry, anxiety, possible biopsy, further imaging. If the nodule is new or enlarging, if there is no cancer history, consider follow-up adrenal CT or dissection. If there is cancer history, consider biopsy or PET-CT, okay, which makes sense because adrenal glands will commonly harbor metastatic disease as well. Okay? And then further down, lesions that are greater than 2 centimeter or less than 4 centimeter will go into adrenal CT protocol. Okay, so if there's no prior imaging, if there's cancer history, if they're in that indeterminate greater than 2, less than 4 centimeter category, then we will put them through that triple phase exam and hopefully we will diagnose it either as benign adenoma with the washout protocol, or if it's still indeterminate, then we can move on to either biopsy, PET-CT, or dissection. But this is a very useful chart to follow because it organizes our process of thinking and diagnosing adenomas. Okay, so we're moving on. Case number 5. This is an ICU patient who is ill with septicemia. This is a contrast enhanced CT. We see bilateral adrenal masses. They're a little bit heterogeneous, maybe have some mild irregularity. Maybe we can say that they're somewhat hyperdense. Okay, so this is a case of adrenal hemorrhage, in this case, bilateral adrenal hemorrhage. It's not always bilateral. So differential diagnosis for adrenal hemorrhage is anticoagulation, septicemia, trauma, burns, stress, shock, hypotension, hematologic disorders, metastatic disease. Usually bilateral, but may also be unilateral, especially in the setting of trauma. It will usually be unilateral. On CT, we're looking for high density mass, usually heterogeneous appearance with counts per units of 50 to 90, just like any other blood products anywhere else in the body. Usually no contrast enhancement. It may distort adrenal shape if it's large, and it will usually have certain amount of periadrenal stranding. On MRI, we would want to see the pre-contrast T1 weighted sequence, just like for any other blood products anywhere else, and it will be hyper intense on T1 pre. Now, adrenal hemorrhage is the most common adrenal mass in a neonate. Okay. So this was a case from SNAP-DX showing adrenal hemorrhage in a neonate, so in a baby. And we see this kind of a heterogeneous enlarged adrenal gland. On this image, it has some cystic components and maybe some septations also. So differential diagnosis in that age in a baby will be perinatal stressors such as asphyxia, sepsis, birth trauma, or coagulopathies. Here is an adult patient, another image of bilateral adrenal hematomas, that kind of a hyperdense, heterogeneous appearance and some mild stranding on the outside. This was a case of a liver laceration from SNAP-DX. There was a mass-like hyperdense area in the region of the adrenal gland, but on other sequences, it was shown that this was actually related to liver laceration rather than adrenal hemorrhage, although it would be somewhat difficult, in my opinion, to diagnose this as definitely liver and to say that this is not adrenal, Okay, they didn't show us other sequences or other pictures, but it's not that uncommon to see something that's of liver primary, but mimicking an adrenal nodule. This is just a companion case showing diffusely enhancing, hyper-enhancing adrenal glands, and for that, differential diagnosis is pancreatitis, sepsis, trauma, or hypoperfusion complex or shock. Which brings us to a differential diagnosis of bilateral adrenal masses versus thickening. So masses where we see defined round or oval, sometimes irregular, 3D occupying lesion versus thickening where there's just more diffuse thickening without defined nodule. So for bilateral adrenal masses, the differential diagnosis may include metastases, lymphoma, hemorrhage, or bilateral pheochromocytomas. And for thickening without a defined mass, we can think about hyperplasia, hemorrhage, metastatic disease, amyloid, sarcoid, hemochromatosis, TB, fungal infection. This was a case where the patient had, as you can see, this is image through the chest, some necrotic pathologic appearing mediastinal lymph nodes and a left hilar mass here. So this was a case of a small cell lung cancer with bilateral metastases to the adrenal glands, which is quite common. In my own opinion and experience, lung cancer is the most common type of cancer that I see metastasizing to the adrenal glands. So if it's a chest CT, restaging lung cancer, I will always look carefully through the upper abdomen, those few images that we get through the upper abdomen, looking, staring at each adrenal, make sure there's not a change or thickening or enhancement for metastatic disease. This is an image of normal neonatal adrenals. So again, in the child, we can see them easier than we can see in adults. Normal neonatal adrenals will be less than 2 centimeters long, less than 0.4 centimeter wide. In my institution, we don't see a lot of children. We have more of an adult population, so I rarely get to see this on my own. But we just need to remember that it doesn't have to be abnormal to see adrenal glands on ultrasound in a child, or especially in a baby, okay? Now, what if we do see adrenal thickening and enlargement on the child or a baby? Then we can think about congenital adrenal hyperplasia. Again, there are those guidelines where by size criteria, we can say that they're larger than they should be, greater than 20 millimeter long, greater than 4 millimeter wide, okay? Adrenal hyperplasia is commonly described as wavy or cerebriform appearance. Here's an adult. You can see adult female with late diagnosis of congenital adrenal hyperplasia. She had short stature and virilization, so they're too long and too thick, right? Normal adrenal glands should be about half the size and not this thick. So differential diagnosis for pediatric adrenal masses may include neonatal hemorrhage, which is the most common mass, as we said earlier, neuroblastoma, Wilms tumor, congenital adrenal hyperplasia, hydronephrotic upper pole of the kidney mimicking an adrenal mass, retroperitoneal lymphadenopathy mimicking an adrenal mass, hepatoblastoma, ganglioneuromas, splenic masses. So several of these are not true adrenal lesions, but they can mimic, they're in the same location as the adrenal gland. Moving down to another case, this was an adult patient who had a contrast-enhanced CT, and we saw large heterogeneous bilateral adrenal masses. This patient underwent an MRI and a PET-CT. You can see again solid heterogeneous enhancing bilateral adrenal masses, but no other lymphadenopathy. There was no other evidence of a primary malignancy elsewhere. The patient underwent PET scan, and the only finding was, again, large bilateral adrenal masses, which were hot on PET. Okay, so this was a case of primary adrenal lymphoma. This was non-Hodgkin's lymphoma that only involved adrenal glands. This is a very unusual case where there was no lymphadenopathy elsewhere in the chest, abdomen, or pelvis. This was primary adrenal lymphoma. Often it will be bilateral, associated with other retroperitoneal disease. In our case, there was no other disease. It can be discrete or diffuse mass. When they're smaller, the shape of the adrenal glands may still be maintained. So metastatic disease and lymphoma will have similar appearance, and it's very difficult to sometimes differentiate. Mets will be more common than primary adrenal lymphoma. Okay. Case number 7, this patient had an MRI of the abdomen, and you can see here on the left side, there's a very large, very heterogeneous mass. It has predominantly solid components, some cystic components, maybe some hyper-intense T1 signal, probably some hemorrhagic transformation on T1 pre. Again, very large heterogeneous mass. Sorry about that. I'm not sure why it just changed. I apologize about the technical issue. I'm not sure why it's doing it, but let's just move on to these smaller pictures. Hopefully it will resolve itself, but we'll just continue looking at pictures like this. So on the contrast enhanced portion of the MRI, you can see some enhancement, very heterogeneous appearance of these masses. So which brings us to differential diagnosis of large solid unilateral adrenal mass. So differential may include adrenocortical carcinoma, metastases, lymphoma, adenoma, pheochromocytoma, myelolipoma, or renal cell carcinoma. So in this case, that large heterogeneous solid unilateral mass was adrenocortical carcinoma. Usually there are very large, solid, irregular unilateral masses with invasive margins. They can be bilateral in 10%. They can commonly have necrosis, hemorrhage, fat, and calcifications, which gives them that very heterogeneous appearance. We need to be carefully evaluating for invasion of renal vein, inferior vena cava, and kidney. And it's a very aggressive tumor. It metastasizes to lungs, liver, and bone. Okay, I'm going to try again. Here's an image of a heterogeneous solid mass with necrosis and very hypervascular appearance from STAT-DX. Here is another picture of adrenocortical carcinoma on the right side, again, some maybe cystic or necrotic components, sometimes calcifications or hemorrhage, solid components. So differential diagnosis may also include, in this mass, pheochromocytoma or metastatic disease. Here's another case of adrenocortical carcinoma with IVC invasion, which is quite common. Okay. Moving on to case number 8. This was an MRI on a patient with bilateral adrenal masses. This is T2 and contrast enhanced image. So we see bilateral, heterogeneous, round, nearly circumscribed masses. It has some increased T2 signal. And on contrast enhanced image, they're very bright. So this is arterial phase. We have lots of intense arterial enhancement in bilateral adrenal masses. So these are pheochromocytomas. 90% of pheos will be within the adrenal medulla, and we call it the rule of 10. 10% will be malignant, 10% bilateral, 10% extra-adrenal, 10% in children. Okay, so classic imaging findings are either unilateral or bilateral adrenal mass, usually 3 to 5 centimeter in size, round or oval. And the classic descriptor that shows up on boards and in-service exams for our residents will be very hyper-intense T2 appearance. We call it light bulb sign, and intense heterogeneous arterial enhancement, which we call salt and pepper sign sometimes. So bright on T2, intense arterial enhancement, typical appearance of a pheochromocytoma. Now, in my own experience, not all pheos will follow these rules. Sometimes it's just kind of a solid, sometimes almost cystic looking mass. Sometimes it will have arterial enhancement, other times venous enhancement. Sometimes it's really hard to be confident and diagnose it 100% by imaging only. The clinical doctors will have to do biochemical assays to put it all together. Now, there are extra adrenal sites for pheochromocytomas, such as the neck, mediastinum, pelvis, bladder, organ of Zuckerkandel, which is near the aortic bifurcation, or vagina even. Here's a picture showing hypervascular solid adrenal mass. This was another example of an adrenal pheo in a 30-year-old patient with hypertension, again, circumscribed, round or oval, heterogeneous, enhancing mass. Here's another example of a pheochromocytoma. And this was a pheochromocytoma mimicking a pancreatic mass on CT. You can see how it's in the region of the pancreatic tail. This is an MRI. We have T1 and T2 and contrast-enhanced sequences. So it has that bright appearance, or at least a part of it is bright on T2, and it has intense enhancement with contrast. So this was an image of a patient with von Hippel-Lindau syndrome. So it has a small left adrenal enhancing mass, which is a pheochromocytoma. It had bilateral renal cell carcinomas and renal cysts. A combination of these findings are typical features of von Hippel-Lindau syndrome. Here is an image of a urinary bladder pheochromocytoma, so they can be extra adrenal. And this will be our last case, where this is an arterial phase, probably a CT angiogram, and it shows coarse bilateral adrenal calcifications, but there's really no soft tissue mass. The adrenal glands are not enlarged. So all we have is coarse bilateral calcification. So differential diagnosis for adrenal calcifications may involve TB, histoplasmosis, fungal infections, old hemorrhage. If associated with a soft tissue mass or any mass, then we can think about myelolipoma, pheochromocytoma, or adrenal carcinoma. Here is a picture of that typical granulomatous disease that we commonly see in the spleen or in the lung. We have those calcified granulomas. It can also affect the adrenal glands, and it will have similar appearance to any other granuloma, kind of coarse, round, or oval calcifications in the adrenal glands. This was a 10-year-old child who was a premature infant, shows calcifications in both adrenal regions, likely due to remote neonatal adrenal hemorrhages. So that old hemorrhage, when the child was a baby, they grow up and they might have calcifications. Okay. And that completes my presentation. I'll be happy to take a few questions if we have time.
Thank you, Dr. Muinov, for that wonderful lecture. It was a great review of all of the imaging techniques we have available to image the adrenal glands, as well as all the various benign and pathologic conditions that we may encounter. We do have several questions in the Q&A box, and I encourage anyone that has any more questions to please enter them in, and we'll get through them all. Our first question is coming to us from Monterrey, Mexico, and it is there a limit in terms of measurement for a child's adrenal glands? And is there a point at which they should be visible on ultrasounds, like an upper age, essentially? She mentions, like, would you still see them in, children 4 or 5 years old versus just in the neonatal period?
Yeah, as I mentioned, I wish I had more experience with pediatric population. I'm an adult body imager, so I rarely get to see it myself. In my own opinion, I've been doing it for 17 years. At that age, I don't commonly see at 4 or 5 year olds, the children that we scanned, a few children. Our technologists will not find a normal adrenal gland to show me. On the baby, I commonly see, adrenal glands. We don't scan ourselves. It might be different in other countries where the radiologist actually goes in and takes the probe. In my institution, I don't scan myself. It's the sonographer's job to scan and show me pictures. But like I said, I don't commonly see normal adrenal glands. But I could be wrong. Like I said, I'm an adult imager, and maybe I just don't have enough experience. I apologize for that.
I am not a body imager, but I do read ultrasound at our institution, and I agree. I don't tend to see them at that age. We do a lot of follow-up of hydronephrosis in pediatric patients.
Right.
Yeah, and as they get older, I don't see it. I tend to see them in like the very young period, but
Yes,
then as they get older, I don't see them at that age.
I agree. Now, if I did see, I have to admit, if a child of 4 or 5 years old, if the technologist were to show me or possibly question something in the adrenal, I would worry about neuroblastoma. The first thing that would come to mind, I would probably be very cautious about things, especially if it's on one side and not the other side. I would have to say that I would recommend an MRI as the next step. And maybe I would be wrong, but the fact that the most common neoplastic mass in a child would be neuroblastoma, I would have to do something about it for me.
Okay, and our next question um, was, and it should have been in regards to when we were talking about the adrenal adenomas. And the question was if you could speak a little bit about the use of PET-CT or MIBG in those cases.
Yeah, in my institution at the University of Nebraska, we rarely, if ever, I don't even remember one case where we would have to do PET-CT or MIBG on adrenal adenoma. Usually we diagnose this either off of CT, the protocol, our adrenal protocol, or MRI. We use them interchangeably. And then we refer them to endocrinology or surgical oncology. Sometimes they will do biopsy and correlate with labs, but in my opinion, PET-CT or MIBG is a rare test, for adenomas at least.
Okay, very good. And our next question was, what were the indications for when the imaging would move to MRI?
Right. So let's say if by CT criteria, we're still struggling. We're not sure if it's a lipid poor adenoma or if it's some sort of other lesion. Let's say, what if we put FIO in the differential diagnosis or adrenocortical carcinoma, metastatic disease, right? It's not that uncommon, unfortunately, of a scenario where those imaging characteristics will overlap. So at that point, we typically will recommend MRI, hoping that MRI might provide some more signal intensity information. What if it looks more T2 hyper intense? And then we see that typical enhancement pattern for pheochromocytoma. What if it has a lot of hemorrhage and heterogeneity and maybe some calcifications? We can perhaps assess margins. We can look at other organs as well. In that sense, it could help, although as you understand, sometimes even with MRI, it's still impossible. We see this ugly looking heterogeneous enhancing mass and we still don't know what it is, and we're still left with the differential diagnosis. But we will commonly use MRI to try to take it further, one more step further, and then MRIs are our last resort. Then from there, if it's still indeterminate, they will move on to biochemical assays and potentially a biopsy or dissection. If it's bigger than 4 centimeters, the surgeons will just take it out.
Okay. And our next question was, do you ever perform an extended CT scan below the inferior mesenteric artery when you're looking for a pheochromocytoma?
Yes, if the indication is to just look, evaluate for pheochromocytoma, then we do abdomen pelvis. We always include pelvis if we're just looking, if we don't know where it is, right? Because we want to see the organ of succulent candle, we want to see the entire retroperitoneum, the bladder, the vagina. I've seen several cases of bladder and vaginal pheos. Now, per clinician's choice, they can also order a neck and a chest. I've seen the big studies where they're looking for paragangliomas, right, in the neck also, or in the mediastinum. So they will order the whole neck, chest, abdomen, pelvis, which is a big study. But more commonly than that, I see abdomen, pelvis. It's never only abdomen if we're just looking for things.
Okay. And our next question is, if you have any experience with PET-CT in imaging of functional adrenal tumors.
I don't read nuclear medicine. I apologize. I can't comment confidently one way or another. It's out of my realm.
Okay. And our next question was, do you recommend image-guided biopsy for the adrenal gland? And if so, are there any certain precautions to take when doing biopsies?
So again, in my institution, body imagers such as myself, we don't do any procedures. We don't do biopsies. We have interventional radiology service who will do, and they do adrenal imaging biopsies. So sometimes they do venous sampling, other times they will do percutaneous biopsy. I know that when we put pheochromocytoma in the differential diagnosis, they will be much, much more careful. They will usually put the patients through the endocrine evaluation, and with endocrinologists or surgical oncologists help, the entire team will present them in tumor board. The entire team will decide whether or not that percutaneous biopsy needs to happen and whether or not it's safe to do, right? Especially if they're hypertensive. But sometimes I see interventional radiology doing a biopsy, but again, unfortunately, I can't comment further. I don't know the entire process of what's involved in that decision making, but we commonly see them in tumor boards being discussed. Usually it's a team approach to those decisions.
Very good. And our next question is about MRI, and if there was any qualitative or quantitative calculations in terms of signal intensity, like there was in the CT for the washout criteria, like if there was a specific protocol or if there's any software designed for that.
I've seen some papers where other institutions are doing it. We don't do it. We don't have it yet. We haven't developed our own protocol where we would calculate the washout. So it's just more of a visual kind of evaluation, more subjective rather than objective. But it's something that's maybe now I will look into with your help and reminding me that it might be an important thing to do. It would be better, more objective to do that. But as of now, we don't do it yet.
Okay, and I think we've gotten through all the questions that we have in the Q&A box at the moment. If anyone has any other questions, please feel free to add them in. We have lots of comments in our chat box commenting on the excellent lecture and the appreciation from every one of our listeners in terms of you giving the excellent lecture and their time. I thank you again for that.
Thank you. It's a pleasure to be here. Have a good weekend. It's Friday.
Right.
All right.
Yes.
Thank you. Goodbye.
And thank you everyone for joining.
Dr. Oliveira, thank you for helping me and introducing me and moderating.
Oh, thank you. I had not done this before, so I was kind of hoping it would go okay.
It was very natural, and so I appreciate it. Thank you. Claude, thank you for your help as well. Good to see you again.
Yes. Good luck later. I'm so excited for you to find out where you're going.
Thank you.
All right. All right. Bye. Thank you.
All right. Bye.
Thank you, everyone. We are going to end the webinar now. Bye-bye.